Good afternoon and welcome to the first OR Today webinar of 2020. We're excited to have over 400 registered attendees for today's webinar. I want to remind you today's webinar is eligible for one continuing education hour. The post-webinar survey and certificate process are automated, so the survey link will be included in the follow-up email, which you'll receive about an hour after this webinar has finished. Once you've completed the survey, you'll be able to download your certificate immediately. Let's start off today's webinar by giving an OR Today Live surprise pack to the attendee that can tell me the answer to the following trivia question. Today's sponsor, Ruhof, is headquartered in New York. How many floors does the Empire State Building have? Answer now using the questions feature on your dashboard. While you're answering, just a reminder to save the date for our 7th annual OR Today Live Surgical Conference, which will be taking place from August the 16th to the 18th at the Omni Interlochen Hotel in Denver, Colorado. Join us to discover new opportunities, broaden your knowledge, and exchange ideas. For more information, visit ortodaylive.com. Okay, let's see who the winner surprise package is, and it is Rebecca Alexander. Congratulations, Rebecca. The correct answer is 102. OR Today would like to thank our sponsor, Ruhof. Ruhof has a full line of surgical instrument and scope care and cleaning products to help you meet and exceed your decontamination challenges. Visit ruhof.com for more information. I'd just like to say that this is a pre-recorded webinar, so there will not be any live Q&A today. Our presenters today are Dr. Lawrence Muscarella, consultant for Ruhof, and Ron Banach, Director of Clinical Training for Ruhof.
Good afternoon. Today's objectives are to discuss best practices for the care and handling of GI endoscopes. We're going to focus on that. Some of the other objectives are to provide solutions to some of the reprocessing dilemmas that you face in your GI and endoscopy units. We want to increase awareness about the risk of GI endoscopes transmitting superbugs. This is not a risk that has diminished entirely. The number of infections appear to have been reduced, but this is still a concern that we'd like to have on your radars. We're going to discuss the importance of adhering to manufacturer instructions for use. That's what IFUs refers to, as well as published guidelines. And we'd like to provide some recommendations to improve safety in the GI endoscopy unit, so that when you leave today and after you see this seminar and this lecture, you will have some tools to actually go back to your unit with and to implement. And if you have any questions about any of this, you can contact Ron or me, and we will provide you with that information at the end.
Larry, thank you. And our audience, thank you for attending today. The first question for today to our panel of Larry and myself is, why has the number of reported E. coli and Klebsiella outbreaks linked to a GI endoscope increased in recent years? And I think this is a topic that we really should focus on as our first question today. So Larry, let's begin.
This is a very good question. Some of you have considered in the past that, for example, with the duodenoscope, for many, many years, there didn't seem to be too many infections. But then as time has gone on, we're starting to identify a lot of superbug infections linked to duodenoscopes. And the fair question to ask is exactly why. Why have things changed? And there are going to be a number of reasons for that. One factor in particular that contributes to this finding is that in past years, these bacteria were generally susceptible to antibiotics. You might say they were able to stay under the radar. So infected patients treated with these drugs could be cured. We didn't have significant morbidity and mortality. Transmissions of these bacteria, therefore, as I said, remained under the radar. Their in effect were invisible. This is going to bring up an important discussion, which we won't dwell on today, but the difference between a transmission of a bacteria and an infection. Transmissions in the past did not generally result in infections, but today, those transmissions are. So for example, however, many of these bacteria today that were susceptible to the antibiotics in the past are now becoming resistant, even to your carbapenems and your colistin antibiotics, which you know and we have heard are called last resort antibiotics. These now are causing a hospital's infection detector radar to light up and to send flags to the managers saying, we have some problems. We now are identifying a cluster of infections that are standing out and are being observed by us because they are uniquely resistant to antibiotics that they were not in the past. As a result, the number of reported superbug outbreaks are now increasing. And again, the primary reason for that is the antibiotic resistance, such that the number of bacterial transmissions that now convert to bona fide infections, in the past this percentage was low, today it has increased significantly due to this antibiotic resistance.
Question number 2. What factors might cause a duodenoscope to remain persistently contaminated with superbugs? And this is a very challenging question for all of us to be concerned with.
Thank you for that question, Ron. There are a number of reasons why, or factors, if you will, that might contribute to a duodenoscope remaining persistently contaminated. And this is what has caused concern in the United States and globally with regard to the reprocessing of duodenoscopes. Why might they be cultured positive and still found to be contaminated with a superbug, even though they were reprocessed according to manufacturer's instructions? Well, there are a number of risk factors for why, despite reprocessing the scope according to manufacturer IFUs, that the duodenoscope might remain contaminated. And these are things that have been overlooked in the past, but we need to focus and understand them very clearly today. The first one is somewhat obvious: breaches of manufacturer reprocessing instructions. Well, if we don't clean and disinfect the scope according to the manufacturer, we may be missing channels or surfaces, and therefore the instrument can remain persistently contaminated. So faulty manual cleaning would be an example. Delayed reprocessing, which we will talk about a little later. That is, not reprocessing the duodenoscope promptly after the procedure. And of course, improper storage. We can do everything right. The endoscope can become colonized and persistently contaminated if for no other reason than storing it improperly. Some have also suggested recently with some post-market surveillance data that's been collected with duodenoscopes in the last year, that users are misunderstanding the instructions of the instructions for use, and that some of the IFUs even feature 100 steps or more. So this is a factor that is contributing to endoscopes remaining contaminated. Of course, we're all aware of complex designs. If the instrument is not designed to facilitate cleaning, it can in turn then hinder cleaning. Damage. This is one of the more overlooked concerns. You can't see inside the endoscope, so you can have a kinked internal channel that you don't even know is damaged, but you will continue to have persistent contamination. So damage is a very important risk factor. Maybe the most overlooked risk factor, because we're all very busy, is inadequate service and maintenance and repairs. If we use endoscopes, just like if we were to drive our car and we were not to change the tires in time, what can happen? The tread can wear out and the tires can explode and cause us problems. So if there's anything that you can glean from today's lecture, this is one of the most important points. Please assure adequate service and maintenance to reduce the risk of persistent contamination. And of course, inaccessible biofilms building up inside the channels. Again, this would be difficult to visualize because we cannot see inside the channels. These are all important risk factors. Please take note of them for a duodenoscope remaining contaminated. We'll now address some of, in the next couple slides, we'll be addressing some safety measures to mitigate these risks. But in the meantime, let's discuss some background information. The types of superbugs that we're talking about that can contaminate a GI endoscope and actually infect patients following ERCP, for example, which uses a duodenoscope, are CRE. And you've probably all heard of this. Carbapenem-resistant Enterobacteriaceae. That might be an E. coli, for example. That's an example of CRE, as long as it is resistant to the carbapenem last resort antibiotic. Carbapenem-resistant Pseudomonas aeruginosa. Some might say, oh, that's an example of CRE because it's resistant to carbapenem. Keep in mind that CRE are only those bacteria that are members of the Enterobacteriaceae family. Pseudomonas aeruginosa is not. So while the morbidity and morbidity of Pseudomonas aeruginosa can be just as significant, it is not CRE per se. We call it a related superbug. And now, very recently, we're hearing reports, particularly out of Massachusetts, in one case, of colistin-resistant Klebsiella pneumoniae being linked to possible transmission by a GI endoscope. That is an organism that is potentially untreatable. That is, can't be treated with carbapenem, can't be treated with colistin, and I'm raising the possibility that GI endoscopy in general, and particularly do an ERCP, may become emerging risk factors for these insidious superbugs. Now, our focus today is on the proper care and handling of GI endoscopes. And as you clearly can appreciate, it is a public health priority. Some considerations to demonstrate that: we have 15 million procedures being performed annually. So if there are risks that can cause GI endoscopes to transmit superbugs, we have a problem because we're not performing nearly 250,000 or 500,000 procedures. We're performing 15 million, and that can produce significant morbidity and mortality if we don't address the risk and mitigate it properly. ECRI Institute in 2019, one of their top 10 health concerns was the mishandling of flexible endoscopes after disinfection. This goes to the title of our lecture about the care and handling and the importance of it. And you may recall that in 2016, the U.S. Congress even issued a report highlighting concerns about duodenoscopes transmitting CRE and related superbugs. So this is a serious public health priority, and all of your coming today to listen to this lecture demonstrates it. Ron, would you like to add something?
Yes, Larry. I've been traveling the country and finding that not only has the GI team been involved with the duodenoscope, but also there's new challenges with all the exciting new therapeutic endoscopes. The therapeutic endoscopes that have been created to do the interventional type of procedures certainly has created more channels. They've created different elevators. In particular, you have your endoscopic ultrasound scopes, which I know is a very challenging scope to clean. Also the bronchoscope, and as well in our laser procedures with 2-channel endoscopes. So it's important for us to know that it's not just in the duodenoscope, but it's the challenges of all these therapeutic scopes. We're doing more therapeutic, we're doing more blood, kind of resection types of things with polypectomies and sphincterotomies. So it's good to be aware of all the different concerns we have on all the different scopes.
Thank you, Ron. I would also add very briefly that bronchoscopes appear to be an under-recognized risk for transmitting CRE and related superbugs as well. And I have a paper in the peer-reviewed literature coming out in a week or two that is a very detailed review of 12 cases that are linking less complex endoscopes and duodenoscopes and linear echo endoscopes also to CRE transmission. So please keep that on your radar.
Thank you, Larry. That was very well done. And I'd like to be able to add now that we have a third question that we're going to challenge you with, which is what safety measures can reduce the risk of a GI endoscope's persistent contamination and transmission of these superbugs? So it complements the last question. Now we're going to try to see what we can do.
Right.
How would you answer that?
Right. Thank you, Ron. Earlier we talked about the risk factors, such as inaccessible biofilms developing, damage to the endoscope, complex design that hinders cleaning. Now let's talk about actual safety measures that can be implemented by you and your endoscopy units and your CSPs to reduce this risk and improve patient safety, because that's just really what our goal is. I'll give you a little animation here. You're looking at the distal end of a duodenoscope, and you see the forceps elevator channel, which has been difficult to clean. That, like the rest of the duodenoscope, as well as bronchoscopes, as well as GI endoscopes, need to be meticulously cleaned. Routine auditing is very important to assure proper reprocessing practices. This is often overlooked. We're very busy, and maybe we do a routine audit audit, I'm talking about an internal audit, not necessarily a joint commission audit or an external audit, but internal, where management can interact with staff and ensure that we're doing things properly, and if we identify non-conformances or deviations, we can promptly correct them. I talked about earlier repair and maintenance as being a major concern of mine. So I'd like you to try to ensure that the proper maintenance and servicing and repair of the endoscope is being performed. And please refer to the manufacturer's IFUs to get a scheduling program so that you know how often to return the scope to kind of be proactive and preempt any type of repair that might cause persistent contamination and disease transmission. Monitoring the brushing and cleaning effectiveness. If we use a brush of the wrong size, we're not properly cleaning the endoscope. So we want to also assure that when we're monitoring brushing, we're using the right brushes. Using a borescope to inspect the GI endoscope's lumens. You've probably heard some of this. Ron will talk a little bit about this, but a borescope will examine the internal lumen as warranted to confirm whether there is damage, biofilms present. And also I stress that we consider not only just for duodenoscopes, but also flexible endoscopes as warranted, performing one or more of the FDA's 4 supplemental measures that it published in August of 2015. An example would be sterilization, ethylene oxide gas sterilization. Another would be culturing the duodenoscope, the reprocessed duodenoscope, I should say, for bacteria to confirm its safety. Would you like to add something, Ron?
Yes, Larry. In my last training program at one of my hospitals that I had gone to, they brought in a new team member that I thought was very active and helpful, and that's the infection preventionist. That person has been a tremendous asset to them in helping guide them and support them. I think the supporting of the issues and the cleaning of an endoscope are now getting the attention I think they deserve in our market now. And I'm glad to see that that happens. Also with Joint Commission inspections, where they're now asking for much greater detail in the documentation of the cleaning process and also the data that you need to back that up. So I think these are areas of positive support for going forward in our proper cleaning.
Thank you, Ron. Well said.
Now, question number 4, which again goes back to which is the best practice following. And we're looking at the best practice either following the endoscope manufacturer's instructions or guideline advice. And what if the two are inconsistent? And I've got this question quite often because there is some conflicts at times. So, Larry, what would you advise us to do in this particular case?
So, in general, the best practice would be to follow both, because both would always be consistent. But the guidelines should mimic, if you will, the manufacturer's IFUs. But in some cases, that doesn't always happen. So we will address that as well as what if the two are inconsistent. So in general, Ron and I recommend adherence to the manufacturer's IFUs, instructions for use. Although there can be some reasonable exceptions. You may remember years ago there was a discussion about using 2% glutaraldehyde during a 20-minute soak off-label or during a 45-minute soak on-label. So the guidelines usually endorse 20 minutes, while the manufacturer's IFU endorsed 45 minutes. So there was an inconsistency. What would you do? In general, we do recommend, as I said, the manufacturer's IFUs, but there may be reasonable exceptions, such as data in the literature supporting another practice. Another example we'd like to discuss is guidelines may advise the pre-cleaning of endoscopes at bedside by suctioning detergent through the endoscope. You've seen these guidelines, you've heard these guidelines, and you most likely practiced this. When you remove the endoscope from the patient, you use detergent to suction through the endoscope and wipe down the insertion tube. This is performed at bedside immediately after the procedure. However, some of you may be familiar with the fact that the GI endoscope's IFUs sometimes recommend, and have been revised at times, to recommend using only water for wiping down the insertion tube and for suctioning through the endoscope at bedside, not detergent. This is an interesting change that discussing this with the manufacturer of your GI endoscope will provide you with more insight, and you can confirm whether the manufacturer is recommending the same as guidelines or something slightly different. So What should you do? We recommend cleaning the endoscope using a detergent, not necessarily water, just water. And as I said, some manufacturers may disagree. We'd like to ensure that the detergent prevents bioburden from hardening, removes and has been proven to dissolve bioburden, and is compatible with the endoscope's materials. A detergent that damages the endoscope's materials but otherwise is great for cleaning is not helpful. The example might be an autoclave. You could put your endoscope in an autoclave to make sure you destroy every organism, but then your endoscope is destroyed, so what good was the autoclave? So this is something very important to keep in mind with regard to our recommendation to consider using detergent whenever possible, not water at bedside to clean the endoscope. Here are some popular standards we'd like you to review periodically and as often as possible to stay up to date and to assure complete understanding of endoscope reprocessing and infection control practices. There are some other guidelines out there, but I thought when Ron and I designed this presentation, we thought we would bring these particular ones to your attention. One other important point I would say is that you review the endoscope model schematics so that you get a sense that for each of your endoscope models in inventory, you know what internal channels there are. Different GI scopes have different internal channels, different internal schematics, different internal designs. One shoe does not fit all feet. So we want to get an understanding of how to differentiate the endoscopes, and this is crucial because of a scenario that we will discuss with you shortly in an upcoming slide. So please understand fully the design of the endoscope, and you can get some information on that through the schematics. So no matter whose advice you would follow, please clean every endoscope channel, even if the channel was not used during the procedure. I think I published a paper in the peer-reviewed literature maybe 15 or 20 years ago focusing on this, but some things unfortunately still get overlooked. Some of you might have read a Reuters article that came out very recently about an Oklahoma hospital that had failed to properly reprocess 3 or 4 gastroscopes used on nearly 1,000 patients. It turned out that the forward water jet of that gastroscope had not been properly cleaned, and that when that channel was flushed, a quote-unquote foreign liquid was discovered in the channel in at least one gastroscope. And as you can appreciate, any foreign liquid is a soil, any soil is contamination, and any contamination poses a risk of infection. I give you the headline there from the Reuters article. So we recommend frequently reviewing the reprocessing IFUs of every endoscope model in your unit's inventory, just like the schematics and the internal design, and ensure that every channel is reprocessed, even if not used during the exam. Please, all of you, promise me that that is exactly what you will do, so that your unit does not have to notify 1,000 patients because some type of debris was found falling out of a channel that you didn't know that the endoscope had, because all the earlier endoscopes you reprocessed didn't have a forward water jet channel or an auxiliary water jet channel, but had, so please just make sure that all the I's are dotted. Ron, would you like to add to that?
Yes, I've also, a good point regarding the idea of the therapeutic endoscopes and their complicated mechanisms they have, to make sure that this is reviewed by the group, and it's not that one technician or nurse taught another technician how to clean the scope, but that you all are on the same page regarding the IFU, and not that there's a step missing, and that you give yourself enough time to clean the endoscope. I think this has really been a big problem that stresses the lab considerably, is the pressure that they're put under to try to turn around endoscopes because there may not be enough available, or that there's a specific scope a doctor wants for a specific procedure that hadn't been planned for. And there you are trying to turn the scopes around, do the best job you can. And you cannot afford now to miss steps. And I think that this would be the best advice I could say to anyone in cleaning endoscopes, is that you know the particulars of every model and that you've learned it from the IFU, and not that if Joint Commission comes in and they ask, well, where did you learn to clean this scope? And you say, well, the last tech that was here taught me. I think that would be not the proper answer. So I think that should be reviewed by all management and staff to be on the same page. And I think this will help considerably in standardizing your cleaning care.
Thank you, Ron. And one thing I would add before we move to the next slide, and thank you for all your attention to this and your interest, is that, again, antibiotic-resistant bacteria is narrowing your margin of safety. It's limiting the ability to make an error and get away with it. In the past, we could make mistakes, and the bacteria were susceptible. They're no longer susceptible. So the importance of very aggressive and robust quality control and management measures to assure proper reprocessing is more crucial today than ever.
Question number 5. Thank you, Larry, for your insight into that particular question. Now, a new question for you is, what is the ideal type of detergent for cleaning a GI endoscope? Can you help us with that question?
As all of you know in the audience, there's different types of detergents that we can use, but they are crucial to cleaning a GI endoscope. We recommend detergents being used in pre-cleaning at bedside, but particularly during manual reprocessing and cleaning in the sink in the reprocessing area. Without a detergent, we're not going to get effective cleaning, or our cleaning effectiveness will be reduced. Some of these detergents contain enzymes, as you're aware, and some might also contain a disinfectant instead. You can refer and talk to the manufacturer, the vendor of your detergent, to get a little more insight into that. But Ron and I came up with a few general characteristics, traits, or properties, if you will, of what we consider an ideal detergent that you should each assure that the detergent you're using in your GI unit actually satisfies these criteria. First and foremost, if you can, confirm with the vendor that the detergent is validated for effective cleaning. If it's just a detergent that someone claims cleans, well, Dawn Soap cleans. But I don't know if that's actually validated for removing bioburden. So please, in the ideal detergent, I'd like each of you to use an ideal detergent. Assure criteria number 1 is satisfied. Assure criteria number 2 is satisfied. We talked about it earlier, that it doesn't damage the endoscope's materials. Assure that the detergent is easy to mix and to dose and to prepare, and that you don't have to go through 100 steps in order to prepare a detergent to use to clean the endoscope. We'd like the detergent to be biodegradable and non-toxic, and we'd like it to be low foaming and free rinsing. And we're basically talking about the detergent not only that might be used at bedside, but also that would be used during manual cleaning in the sink. So these are the characteristics we'd like you to consider and adhere to when you are using a detergent. So if Joint Commission comes in and says, well, what kind of detergent you're using, have these checks available, and the more of them that you can satisfy, the more CMS will look at you or Joint Commission and say you're doing a very good job.
Thank you, Larry. The next question we're looking at here is, what are the key steps in the proper care and handling of an endoscope? A challenging question because there are so many variables involved. We want to make sure we're trying to cover as much of the topic as possible for you. So we will try to focus on those key steps. Larry, which ones would you feel are appropriate here?
This is probably the most important question of today's presentation, and it's what probably attracted you to the title of this presentation. It's what are these key steps in the proper care, handling, inspection, and prevention vis-a-vis GI endoscopes. So proper care, as you all know, is crucial and important to public health, and we're going to give you some specific examples to demonstrate that and prove that in a second. But right now, let's take a look a little bit at the animation here. Immediate pre-cleaning is your first step at point of use or bedside. You want to safely transfer the endoscope to the reprocessing room. You want to, of course, leak test the endoscope, and if it fails it, the leak test, do not use it. Contact the manufacturer and probably return it to the manufacturer for repair. Prompt, meticulous manual cleaning followed by visual inspection of the instrument. Earlier, we said we'd like immediate cleaning after bedside, but now we're talking about prompt, meticulous manual cleaning in the reprocessing room, a distinction that we will bring to your attention in a future slide. High-level disinfection followed by water rinsing. Keep in mind, we'd like this water rinsing ideally to be sterile. Then it would be bacteria-free, filtered. If it's tap water, then please assure that you are terminally drying the endoscope with typically 70% alcohol and forced air. We want you to assure that there's safe, proper storage to prevent recontamination. And we'd like you to track and document the GI endoscope used on each patient so that if there's any kind of a recall or any type of an outbreak, we know that if we identify a quote-unquote suspect GI endoscope that has inaccessible biofilms in it, that is damaged, or that otherwise could pose a risk of persistent contamination, we know exactly which patients that GI endoscope was used on. And then if we had to notify patients, the number of patients that we had to notify would be significantly reduced. Instead of kind of macroscopically notifying 5,000 patients, because we couldn't track the GI endoscope to the patient, we might only have to notify 200 patients, significantly reducing risk. We emphasize, therefore, that in endoscopes, improper care can pose safety risks. That's the flip side. We stress that proper care is crucial and improper care can pose safety risks. Here's an example for you. I went through the FDA's database and I found that in July, an adverse event was filed by a manufacturer. And this manufacturer informed the FDA that, quote, the steel from around the lens of a bronchoscope was found inside the patient's airway after intubation, unquote. Something we obviously would be very concerned about. Injuries are not just infection related. They can also involve, for example, injury due to a component of a device falling off inside the patient. This particular regulatory report filed in July further states that the improper maintenance may have contributed to this adverse event. So again, these are not just hollow words to say we want to maintain the scope, we want to care for it, we want proper care, we want to inspect it. This can have real life consequences if we deviate from the standard of care and the necessary practices. Manufacturer in this regulatory report advised something that all of you are aware of, but I want to underscore. The report states by the manufacturer, do not, quote, strike, bend, hit, pull, twist, or drop the endoscope's distal tip or distal end on the floor or damage its insertion tube or bending section. And why? And to do that with excessive force. And to why? It isn't as if you have nothing to do on a Friday afternoon, but take that GI endoscope and start slamming it against the wall. Maybe it was a tough week, but you have other ways of assuaging your stress. Because certainly doing this, the banging an endoscope against the wall with excessive force can cause parts to fall off in the patient. And this particular slide focuses on bronchoscopes, but I want to mention this is not unique just to bronchoscopes, but also can apply to all other types of endoscopes, as well as certainly GI endoscopes.
Larry, going back to that point regarding the change in endoscopy, we also have a physician that's doing the endoscopy, and I know that now with the new types of procedures being done, particularly in the therapeutic area of endoscopic mucosal resections, the sphincterotomies, and even laser ablations, we have physician skills, and we also have nurses watching and being observant to how the scope is being handled. And to make sure we do a thorough inspection after those therapeutic procedures, I would advise to be an important step to add to your cleaning process as well.
Thank you, Ron.
So now for question 7, we're going to move into an area that is very, very interesting. It's been brought up as a new area of confirming, and these are monitoring kits that are available to assess how effectively a GI endoscope has been cleaned. It's an area that has been available, but now I believe it's becoming part of the routine of endoscopy cleaning. Larry, can you embellish on this area for us, please?
Yeah, thank you, Ron. I won't spend too much time on this slide, although it is of an important topic, simply because we have a couple other topics we want to get to today and give you time to ask some questions. But there's several kits that are available. And in general, these kits, as you may know, are used to measure and quantify the amount of residual debris or a marker soil quote unquote, that remain on the instrument. They're used to monitor cleaning effectiveness. They may also be used to assess cleaning competency of staff, to detect possible endoscope damage. For example, you clean the endoscope thoroughly, but you keep finding a marker soil in the endoscope when you use one of these kits. That should raise an alarm that the internal channel may be kinked or damaged. And also, if a vendor provides you with a new detergent or cleaning brush, you would use it, and then you would assess how well does it compare to your current cleaning brush and detergent. You can use these kits as part of a quality assurance program for these particular reasons. The types of residual soils or marker soils that these kits use or may use typically include, and many of you have heard about this, proteins, hemoglobin, and adenosine triphosphate. These are marker indicators of cleanliness. Now, in 2015, the FDA recommended culturing duodenoscopes for bacteria as a supplement to evaluate reprocessing effectiveness. But I want to just mention that there's a distinction between monitoring the presence of bacteria in a GI endoscope and assessing cleaning effectiveness via these marker soils. And keep in mind that this particular culturing of duodenoscopes requires training in aseptic technique and also has been somewhat controversial because the endoscope will be quarantined for 2 to 3 days pending the results. If no bacteria grew, the endoscope would be considered safe for use. If bacteria did grow, then we'd have to reprocess it again. In contrast, however, these cleaning monitoring kits do not require, per se, aseptic technique or quarantining the endoscope or purchasing $1 million of new endoscopes to account for the downtime. They can provide results in minutes, are performed in the reprocessing, namely the cleaning room, and are easy to use. But again, we just want to stress that these kits are used to assess cleaning effectiveness, not the amount of bacteria remaining on a scope after disinfection or sterilization.
Thank you, Larry. I'd like to bring up question number 8. How soon after the procedure should the GI endoscope be cleaned in the sink?
Thank you, Ron. And when we say in the sink, we're not talking about bedside, so I just want to clarify that distinction. This is a question that's often asked, and one guideline recommends that manual cleaning begin as soon as possible after the endoscopic exam or the procedure to prevent drying. But what is as soon as possible? We've all asked it. Is it 5 minutes after the procedure? Is it 30 minutes later? Can I get away with 10 hours later? What exactly is as soon as possible? Ron and I recommend brushing and cleaning the endoscope in the sink, that it begin promptly after the exam, which then creates the issue of what does promptly mean. We define it as less than 60 minutes. Please note that if the cleaning is delayed for longer, some manufacturers may advise pre-soaking the endoscope in a detergent to prevent biofilm formation. Please contact the endoscope manufacturer and discuss with the manufacturer whether it advocates or promotes pre-soaking. Unnecessary long-term immersions can damage the scope, so you'll have to write into your policies and procedures this. Assure that at all times the endoscope is cleaned manually within 60 minutes of the procedure, if not less. And if we exceed 60 minutes, we may have to do prolonged soaking. And you may ask, where did that 60 minutes come from? It's because that's where the manufacturers, during their testing for the FDA, they allowed the scope to sit for 60 minutes and then demonstrated that the reprocessing IFUs were effective. Times greater than 60 minutes, there's no data to suggest effectiveness. So that's where we came up with the 60 minutes, and we ask that you try within 15 minutes to reprocess that scope in the sink.
Thank you, Larry. That's good, very good details. Now for question number 9, what is the best practice for safely transporting a soiled endoscope to the cleaning room? And must my unit differentiate a clean from a dirty area? Good question, and I'd like to get your expert opinion on that as well.
Thank you, Ron. Soiled endoscopes should be transported to the reprocessing area in a container that's closed and covered, that's labeled as a biohazard, designed not to damage or overly coil the endoscope, and is puncture resistant. This is important to prevent exposing staff in the environment to potentially infectious materials. Most of you are aware of this. You can refer to some of the guidelines that will list these specific characteristics if you would like some confirmation of them and more information about them. Certainly, we recommend differentiating clean from dirty. Our goal is to prevent recontamination of the endoscope. So specifically, please assess the design of your unit and try to satisfy these criteria. It's important because this will reduce the risk of infection in your unit and will cause you to be even that much more in compliance with Joint Commission's expectations. You want to physically separate the procedure room from the reprocessing area. This is not a given. I have read and am aware of instances in which the procedure room where the GI endoscopy was performed is in the same room as the automated endoscope reprocessor that's reprocessing the scope. Same as in the procedure room. Not good. And we want the reprocessing area to be separate from where the endoscope is stored. Otherwise, the endoscope can be recontaminated. We'd like the storage area to be clean, dry, and well ventilated. You're familiar with that. The upshot of this is we'd like the GI unit's workflow to move from dirty to clean. Again, we want to separate the zones so that we are not cross-contaminating and recontaminating a clean or disinfected endoscope with soil and then inadvertently using it on the patient. And also remember, whenever you think an endoscope might be contaminated with soil because you inspected the internal channel with a borescope or you saw it on the external part of the endoscope after reprocessing, please speak up. Please send that scope back to reprocessing and send it back into the system, the loop, have it reprocessed again until no more debris is visible. And we'd like you to design the unit to prevent recontamination of the GI endoscope, as we're talking about, so that when it's transferred from the storage area back to the procedure room, the endoscope has not been recontaminated with soil and is safe for use.
Larry, that's very helpful. And also there is guidelines within all the professional societies that can certainly be referred to help in solving any questions regarding the workflow or how an endoscope is transported through from the procedure room to the cleaning room and then through for high-level disinfection back into the cabinet. So let's move on now to question number 10. In question number 10, should my unit use duodenoscopes or ERCP scopes with disposable components? This has been a very hot topic, one that the FDA has gotten involved in, and one that is extremely challenging for the technicians to be responsible for cleaning the scope when maybe there's not a way to clean the scope. And Larry, I'd like to address this with you now for the audience to see what you would say in this regard. How would you answer this question?
Thank you, Ron. And this is our last question. And again, I thank all the participants for their attention to our questions and to listening to our answers. Recently, the FDA came out with an edict, if you will, asking that hospitals begin transitioning from the traditional duodenoscopes we've been using to those with disposable parts or components, or what we call an end cap. So on August 29th, the FDA recommended this practice and wants this transition to begin. And I could probably talk for about 20 minutes or 30 minutes just on the slide, so I will be brief. According to the FDA, disposable design, and of course we would all agree, simplify or eliminate reprocessing. Assuming you're not reusing a disposable device, there would be really no reprocessing at all. And this may improve safety compared to the reusable duodenoscopes that feature a fixed end cap, which are the ones you're currently familiar with. We call these traditional duodenoscopes. Question then is, when or how will this process begin? We foresee facilities in the near future beginning to adhere to the FDA's recommendation and to transition from the conventional duodenoscopes to models with single-use removable end caps. The purpose of the removable end cap is so that you're able to get a brush into an area that hitherto we could not adequately clean. So by removing that end cap, the FDA suggested reprocessing will be facilitated. Alternatively, the FDA suggested that we begin evaluating as time goes on completely disposable duodenoscopes, of which currently there are none available. There are a number of issues that come up on this, which I will discuss just now very briefly. And that is, will these, from a performance standpoint, will these disposable or quasi-disposable duodenoscopes perform as well as the conventional ones? Are hospitals going to be comfortable getting rid of their current conventional endoscopes, which they may have spent a lot of money on, to simply replace them with disposable duodenoscopes, or at least duodenoscopes with the disposable end? These are a number of issues that we need to think about, and we encourage more research to identify which specific disposable endoscopes or those with disposable end caps are more effective. And we want to make sure those end caps are not falling off in the patient. We talked earlier about a bronchoscope having components at the distal tip that might fall off in the patient. We want to make sure that the designs of these duodenoscopes do not also encounter that. Sometimes you can solve one problem, create another, and I'm not suggesting that's happening here. I'm simply raising questions that this may not be a panacea, but we can talk at a future time about mitigations using these disposable duodenoscopes so that we can assure the safety of your patients and the efficiency of your unit. That is our presentation today.
Thank you, Larry and Ron, for an informative webinar, and thank you again to our sponsor, Ruhof. Just a reminder that the post-webinar survey and certificate process is automated, so the survey link will be included in the follow-up email, which you'll receive about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card for completing the survey. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information on our upcoming OR Today webinars, please visit our website, ortoday.com. Thank you again for joining us today. We hope you enjoy the rest of your day, and we hope to see you next time.